Welcome to The Explainer. Today, we're breaking down the absolutely critical protocol for managing acute respiratory failure. We're talking about a life-threatening condition where something as simple as breathing becomes a massive struggle. So, let's walk through this step-by-step guide that doctors use when every single second counts.
So what really happens when breathing fails? We're going to follow the entire clinical journey, right from the very first signs of trouble, through the huge decisions that can completely change a patient's outcome, and all the way to the careful, deliberate path to recovery. This is basically the playbook for one of the most urgent challenges in all of medicine.
All right, here's our game plan. We'll kick things off with how to even spot respiratory failure. Then we'll get into diagnosis and the different hospital pathways. And finally, we'll cover the road to recovery and all the key numbers that guide the entire process.
Okay, let's dive right in. The very first step in a crisis like this is just recognizing that it's happening. With respiratory failure, the body sends out some really clear and often pretty dramatic distress signals.
Clinicians are trained to spot these physical signs immediately. Think of them as the body's alarm bells going off. You've got shortness of breath even when resting, a racing heart, a bluish tint to the skin, and even drowsiness or confusion as the brain starts getting starved of oxygen. Every single one of these is a critical piece of a life-threatening puzzle.
But here's the thing. It's not enough to just know the lungs are failing. Doctors have to know how they're failing, so they classify it right away. Is it type 1, where the problem is getting oxygen in, or is it type 2, where the problem is getting toxic carbon dioxide out? This one decision is so important because it dictates everything that happens next.
For type 1 or hypoxemic failure, this is the number that matters, a PO2. That's the partial pressure of oxygen in the blood. Dipping below 60 millimeters of mercury, that's the red line. It's the hard data point that says, hey, the body is starving for oxygen.
And for type 2, the hypercapnic kind, it's all about this number, a PaCO2, the partial pressure of carbon dioxide climbing above 45 millimeters of mercury. Well, that's a clear signal of a toxic buildup. The body just isn't getting rid of a critical waste product.
So, once the type of failure is nailed down, the team hits a major crossroads. The path forward isn't just about the medicine, it's also about logistics. What they do next depends entirely on the resources and the capabilities of the specific hospital they're in.
Let's start by looking at the pathway in what's called a secondary hospital. These places might have more limited resources, so the big focus here is on getting the patient stable and providing that immediate, fundamental life support.
The first line of defense is simple and direct. Get the body more oxygen fast. The team escalates their approach. They'll start with a simple nasal cannula, but if that's not cutting it, they'll move up to more powerful gear like a non-rebreathing mask. The goal is just to flood the system with the oxygen it's so desperate for.
At the very same time, doctors are attacking the root cause with medications. If the airways are clamped shut, nebulized bronchodilators can help relax those muscles. For inflammation from something like COPD or asthma, IV steroids are used to bring down the swelling. And if the lungs are actually filling with fluid, IV diuretics help the body get rid of all that excess liquid.
But this initial approach has its limits. If the patient's oxygen levels keep dropping, if their breathing muscles just get exhausted, or if they just aren't getting better after 2 or 3 days, the protocol is crystal clear. They have to be transferred to a more advanced facility.
Okay, so let's follow the patient to a super specialty center. This is where the heavy-duty technology really comes into play, with machines that can literally take over the entire job of breathing. So the first step here is often non-invasive support. That means using a tight-fitting mask to push pressurized air into the lungs. It works really well for type 2 failure. But when that's not enough, or if the patient is just too sick, the team has to move to invasive mechanical ventilation. That means a breathing tube goes directly into the airway and the machine takes complete control.
And this is so important to understand. It's not just about the lungs anymore. When a patient is on a ventilator, it requires a whole body support system. We're talking about keeping the airway clear, propping up the head to prevent pneumonia, making sure they get nutrition, and using medicines to stop things like stress ulcers and dangerous blood clots.
The whole goal of the ventilator isn't just to pump air in and out. It's to hit a very precise biochemical balance. The team is constantly tweaking the settings to hit these exact targets, a PO2 of around 60 and a PaCO2 of about 40. It's all about restoring the body's delicate natural equilibrium. So let's say the patient is stable and the underlying problem is getting better. The journey is still not over. Now comes one of the most critical phases, weaning them off the machine and seeing if their body is actually ready to take back control. And this is absolutely no time for guesswork.
Doctors use a very strict checklist. Is the acute illness getting better? Is the patient's heart stable? And crucially, can they keep their oxygen levels up while the ventilator is providing less than 50% oxygen, a measure called the FiO2? They only move forward if every single one of those boxes gets a check.
This number right here, this is the green light. It's called the Rapid Shallow Breathing Index, and it's a pretty simple calculation of breathing rate divided by the volume of each breath. If that score comes in under 105, it's a great sign that the patient is breathing efficiently and strongly enough to make it without the ventilator. It's a really powerful predictor of success.
And what about the small group of patients who need support for a long time? Well, having a breathing tube in the mouth isn't a great long-term solution. So after about a week to 10 days, a tracheostomy, which is a surgical opening in the neck, might be created to provide a much more stable and comfortable airway.
Okay, we have covered a ton of ground. So, as promised, let's pull all of the critical numbers from this entire protocol together. This is the hard data that guides every single decision along the way.
All right, let's quickly recap that initial stabilization phase. You can see the escalating support here, from the lower flow rates of a nasal cannula all the way up to the high oxygen concentration of a non-rebreather mask. And right below that, you've got the key medications: bronchodilators, steroids, and diuretics, each one targeting a very specific underlying problem.
This table really puts the entire journey into perspective with just the numbers. Over on the left, you've got the diagnostic thresholds that sound the alarm in the first place. In the middle, the precise targets they're aiming for with ventilation. And on the right, the green lights for recovery, needing less than 50% extra oxygen, and of course, that key rapid shallow breathing index score below 105. So in the end, this whole structured protocol provides an incredible, life-saving roadmap, a clear path through a really dangerous crisis. But a map is just a map. Ultimately, it's the skill, the intuition, and the adaptability of the medical team that truly navigates the unique and unexpected terrain of each individual patient's journey back to health.